So it is my great pleasure to introduce Samar Aoun, who is, I think, well known to Western Australia and well known to the rest of Australia for her work in this space. So please, I'm not going through biographies until it gets to me, then I'll tell you all about myself. But the biographies are on the table, so please welcome Samar.
Yeah, hi, we made it. That's amazing. But following Professor Kelleher, we need to start making babies. That's a really good one. Public health and palliative care, the babies are those compassionate communities, and they are at different stages of growth. So that's a really good analogy, I thought. Welcome also to the ones online. It's great to have everyone join us today. Do you have do I just put enter? No, I think so. Yeah, okay. Yeah, thank you. So, we only live once. We keep saying this until now we're changing it. We only die once. And so, if we only die once, how can we make it a good one? We only have one shot at it. And we can do it well in this country. We don't have wars that's going to kill us before we can make decisions how we want to die. So let's get going. Now, palliative care is a basic human right, and we have wonderful, wonderful services in Australia and the developed world. But is it accessible to everyone? No. Is it accessible everywhere? No. Is it still an aspiration? Yes, even in Australia. There's so many gaps. And this is where compassionate communities come and fill those gaps, because the community is missing from being a good partner with palliative care. So what we need to aim at is every person, every family, and every community knows what to do when someone is caring, dying, or grieving. It's got to affect all of us, 100% of us. So we think maybe it's an aspiration, compassionate communities, but with the research evidence, we proved it's a practice, and it's a practice for system change. It is committed to that, and this is what I love about it, not just because it's just inclusive, but if you attended the last palliative care conference last year, we've had fantastic presenters, but again, everybody was finishing their presentation. We need system change, we need change in paradigm, and we hear this every 2 years at the palliative care conferences. And then I'm saying to everyone, who's going to do this system change for us? We need to do it. There's no one else. I mean, we're going to keep saying it every 2 years, or also in any forum that we have. But if we don't get together and do this system change and social change, nothing is going to happen. So the community needs to be an equal partner, and this is what public health palliative care is about. And therefore, we need a shift in the culture of care and support, care that's more sustainable and affordable, and high levels of community control and ownership. So I won't go through what Professor Kelleher has already said, that 5% of us are in contact with formal care, and the 95% is us, the community. But what are we doing to those 95%? They have been de-skilled throughout the years. They were much stronger decades ago when they were caring for us. So when we did our national bereavement survey, again, you can see that family, friends, funeral providers even have given we were told by the bereaved people, this is where they had the majority of their support basically from. Then you have about 30% who have leaned on health professionals, not necessarily specialists in palliative care, but you go to the pharmacist, you get your medication, you're able to sort of have a chat as well, and the GP obviously. And then only 10% really went to health professionals in bereavement support. And that's it, basically. When we were told for a long time, if you have a death in the family, you really need to go and see a counselor. So that gave rise to the public health model for bereavement support, and it's based on what communities have said and people have said. So the 60% is a low risk, 30% the moderate risk, and only the 10% are the high risk. And so when we asked them how helpful was this support, the blue lines, it says again, family, friends, and funeral providers have been really helpful compared where you see the red is more in the, or not helpful among the other groups. So we can't get rid of grief. Once we have it, people think that grief slowly gets smaller with time. In reality, grief stays the same size, but slowly life begins to grow bigger around it, and this is where compassionate communities fill that space. So the key learning from this bereavement support national group findings, the community needs to own its central role in end-of-life and bereavement care, with professionals advising, supporting, and contributing as required. We need the support of these everyday assets in our communities who care for the bereaved and who are already involved anyway before we get to the bereavement stage. So where did this model go? It's gone worldwide. The Irish Hospice Foundation had used it, the National Bereavement Alliance in the UK, European Association for Palliative Care. It resonated with everybody, basically, which makes common sense. This is what I've been told. So where are we going with Australia? The number of people who are going to die is going to double. But they are doing this not really the way it's been done. It's not reflecting their values and their choices, because we don't really discuss what are our values and we don't know what are our choices. And this is what we call death literacy. And so a lot of people keep going to the hospital towards the end of life, which really is not necessary if we have a death literate community. So as Professor Alan Callagher, you have seen, death is a social event with a medical component. It is not a medical event with a social component the way it's become now. And again, it won't kill us to speak openly about death and dying. So dying is still increasingly becoming institutionalized in Australia, according to the latest statistics. The majority of palliative care admissions end up dying in the hospital. It's much more expensive, 14 times higher when we're dealing with somebody with end of life. Our modern death has become cellular, curtained, individualized, and obscured. We don't see death enough around us. And this is about here the advanced healthcare planning, which WA Health and Palliative Care WA have been working tirelessly to increase the numbers of people who will die with an advanced care directives and have those end-of-life discussions. But still it's very, very low, but it will get there. But what we've done is that we've come with this concept about filling those forms to a community that's not well prepared for death. So we asked them to fill in those forms that are really complicated. And so we've put the cart before the horse. So as the community becomes more death literate, I think we'll see an uptake in advanced care planning. Social isolation, I think that's going to be the biggest killer, and the most recent reports are really saying this. Around 1 in 5 older Australians are socially isolated. This rises to a third in residential aged care facilities. And it's the same all over Australia. And it's the same for all the aged cares as well. Look at the young people. It's even more than the other groups. So social connectedness cannot be ignored. It is a health determinant for mental and physical health, and people who are socially connected are happier, physically healthier, and live longer, and the opposite is true. Again, another big trial showed that social relationships have had more of an impact on reducing mortality than reducing smoking, reducing your BMI, exercising more. So we really need compassionate communities to be everywhere, basically. We really need to build those resilient networks around us. We really need to build those trusting relationships between health and social care teams to have more equity of services. Of course, the financial savings cannot be ignored. So let me tell you quickly about the Compassionate Connectors program. The connectors are the ones who are building the capacity of the community. They are looking at who can help somebody in need. And they call on what we call the caring helpers, and they are community citizens, is a better word really of saying. And these are the people who have been able to help the patients with life-limiting illnesses that were referred from the health service with, you may think they are little things, but these are really big things in the scheme of somebody who is dying and they want to normalize their life. So those community volunteers are trained to diagnose suffering, not diseases. And so we've had 85 families referred, but because they are towards the end of life, we've lost nearly half of them before we could collect the data. 47% were home alone. Median age 74 years, 44% were male, and this is what they were suffering from. Now, what did they actually need? This is the domains where we were able to offer support in the Connector program. You can see in red the social. Nearly 80% of people wanted just social contact. So these are the domains where they were able to help. They've helped families to join more community groups, all-time dancing and so on. They've had surrogate grannies for family with kids, transport people. But the most important thing is that message, you can do it. And this is what Steve will be talking about. So the connectors have sourced externally facilitated networks, not really related to those families in 59% of the cases, because they were home alone, half of the patients who came to this program. And so we improved social connectedness significantly, doubled the amount of social support these people could have. And when we asked them about the impact of this program, highest impact was in reduced social isolation and then coping with daily activities. The families rated this impact a lot more than the connectors, who were really very modest about their impact. So this is like a family before the intervention, and this is a family after the interventions, where there's more buzzing around it, helping them. So compared to a control group, there was a significant decline in the frequency of hospitalizations of those patients, and a significant decline in the number of hospital days, because they're not admitting themselves for social admissions or when they panic about their condition, because they have people who love them in the community. They can call them first now. And there was an increase in the use of outpatient services, because these, again, community citizens were making those appointments for them and driving them there, which means the net savings over a 6-month period, if we had 100 patients and 20 connectors, it would be just over $500,000 every 6 months. So this is really very important when we're looking at models of care. Again, the latest research from Europe showed that people reporting greater loneliness around 1 year before death were more likely to experience burdensome symptoms like breathlessness, anxiety, or sadness and pain in the last months of life, compared to people reporting lower level of loneliness. So these are just some photos of the caring helpers at home. So what is so distinctive about this form of volunteering? It's got more autonomy in it, more agency. It sustains social capital with emerging genuine social encounters, and it's fresh ways of engaging with the community. I mean, we we need to reach a day where we don't need such programs, because every one of us become connectors, the same old way we used to do it. And so just 2 quotes of the connectors, what they thought about this, which I'll go quickly because we don't have time. So where do we go from here? Translation is so important, whether it's in practice and policy. And this is where Compassionate Communities Australia would be aiming towards. Again, the health service is looking at integrating this, and this is where we call the system change that we are looking at. A lot of interest all over Australia. And then local government. Again, local government is very important in this. And when we talk about system change, we really need specialist and generalist palliative care and civic organizations and community networks to all work together to have a affordable and sustainable system. And Dr. Julian Abel has done a good job into putting this where all the cogs of the wheels of all these organizations need to be working in synchronization. Now, look at this chain. The chain is the one that's making them really work well together, and whose responsibility it is? All the health departments. And Gabriella is here. Thank you for being at the forefront of this. When you gave money to local government to start working with compassionate communities, we were able to do the city charter. So this is where things, again, the latest thing on the aged care crisis, we need more integration between aged care facilities and the community. We need more efficient models of care as Australia's population ages. Here's one. There's so many. But I mean, we really need to look at it. It's all in the report. Who is going to activate that? We'll see. So with the Compassionate City Charter, it was really important to give this higher level sort of vision of how your city can be a compassionate city. And so these are from the focus groups that we've done in the community, these are the 10 aspects of care where people wanted to grow more compassion in Bunbury. And it's based on the Ottawa Charter, which again, Stephen will talk about that. But this is again where you build healthy public policy and reorient healthcare services. And this is what we need to do. So why we need a compassionate charter? Because it is a systematic way of ensuring we build compassionate communities across all sectors. And I'm saying all sectors, basically. So where to from here? Compassionate Community Australia. 65 presentations and media interviews last year. I'm sorry if you've heard me talk about all this before. Some of you may have. But it gave me the opportunity to listen to all these communities where I presented. And all are saying we need a national voice, we need an effective voice to have a seat at the table, to drive all the good work that communities are doing, because we need community-led solutions. I mean, look at the public health model for bereavement support. It came from what the community said, and it's resonated everywhere. So as you can see in your brochures, it's a peak body for everybody. It's about advocacy and policy development, conducting research and sharing the evidence, which is really important, building partnerships with the formal and informal networks. It's about education and development of resources, and also supporting community-led programs. So it'll be a hub where people know where all these things are happening and what's going to work for their communities, their age groups, you know, that they are dealing with, and they know where to find it. So really the final outcomes for all of us, wherever we are, whoever we are, we need to ensure that when caregiving, dying and grieving knock at our door, that compassionate support will be found in all aspects of our life.